Yeah.
Okay. Good afternoon, everyone. The topic for today's talk is Slet Shines Enhancing Post-Slet Cataract Surgical Outcomes in Post-Slet Patients. So, okay. So there is only one case report till now on post-SLET patients who have undergone cataract surgery. Hence, we did a research on 7 to 8 patients of a case series of post-SLET patients that have underwent the cataract surgery. This is a retrospective study of 224 post-SLET patients from April 2019 to February 2024. SLET is a surgery in which 2 by 2 millimeters of limbal tissue from the unaffected eye is harvested and transferred to the affected eye, mostly which has underwent any chemical injury or mostly a Lyme injury. And here we aim to highlight the pre-operative planning, intraoperative nuances, and post-operative outcomes of cataract surgery in the eyes which have undergone SLET. In the first image, you can see a 360-degree limbal stem cell deficiency and the vascularization of cornea reaching the central 3 mm zone. The next picture is a post-operative day 1 picture of the patient who has undergone SLET. And the third picture is a 6 months post-op picture which has underwent SLET. You can see the clearing of the cornea, and there are no vascularizations, hence the vision has improved to 6/12 parts. So what is the cause of diminution of vision in these patients? You can see there is pannus and some vessels that is growing in the central 3 mm zone. So this is the cause of diminution of vision in these patients who have limbal stem cell deficiency. Also, these ghost vessels may exist in post-op period of 6 months or 1 year also. Hence, the visual acuity is not perfectly improved to 6x. Now, why the post-SLET cataract develops? The most important reason is long-term use of topical steroids that we give in post-SLET patients to grow the stem cells properly and to prevent the rejection. The other is the chemical injuries that occur during the injury of the unilateral eye, like Lyme injury, that can even lead to cataract. Also, pre-existing trauma, and mostly these cataracts are posterior subcapsular. What are the pre-operative nuances that should be considered in these patients? Due to chemical injury, these patients mostly have a symblepharons, superior or inferior symblepharons. There are areas of corneal thinning, and sometimes these may have signs of failed SLET, like vascularization growing from the nasal or temporal areas. Also, the corneal opacity and vascularization hampers the cataract surgery. For the corneal evaluation, thinning and epithelial defects must be considered, and we should always keep a corneal tissue standby while performing cataract surgery in these cases which have corneal thinning. We must avoid the high phaco pressures and high infusion pressures while planning phaco in these patients. If there are corneal irregularities, it poses a difficulty in IOL power calculation. In these, pupilloplasty and optical addictomy can be done. On ASOCT, we should always do an ASOCT for these patients to suspect corneal thinnings. In failed SLET or LCD, an OPK with ECC can be performed as a combined procedure. What are the intraoperative challenges that we may get in these patients? Mostly these are vascularized and opacified corneas. So the phaco incisions should be planned at the sites with clear corneas. Also, the patient must be counseled for adequate duration of surgeries, and the surgery must be planned in a peribulbar or retrobulbar block. The rhexis flap must not be left in the hazy parts of cornea, as identifying the flaps will be difficult. We can place the OVD and replenish the OVDs frequently over the cornea for better visualization, and ASOCT findings must be considered before planning the choice of surgery between phaco and ECC. Biometric considerations. A video keratography can be done or an IOLmaster can be used for determining the K values. In central 3 mm zone, average K values can be used. Significantly scarred corneas, standard K values, that is 44-45 diopter, can be used. We must avoid any multifocal or toric lenses in these cases, as it may lead to refractive surprise. If there is difficulty in visualizing capsular bag, or margin, we must place a multi-piece IOL in the sulcus. Also, the patient must be counseled for a refractive surprise. So these are the results of our study. Mostly the patients had the PSC or dense PSC. In the initial 4 cases, we performed the phaco surgery, and visual outcomes were better than 612 in all of them, 618 in all of them. And in 2 cases, we did ECC with PMMA, in which the visual outcome was 612 and 660. In 2 cases of failed Slet, we did a combined procedure with OPK, a small graft OPK with ECC. So the conclusions are, it is challenging preoperatively and intraoperatively to operate a post-Slet patient for cataract surgery. Steroids hastens cataractogenesis, specifically posterior subcapsular cataract, and which is quite symptomatic. The IOL calculation is a challenge, and irregular astigmatism can be tackled by using scleral or can be tackled by scleral or rigid gas permeable lenses. Thank you.
Thank you. See, you spent 4 out of your 5 minutes giving us a general overview of Slet and cataract.
Yeah.
Instead of telling us specifically in the patients that you tackled what you found. Because the conclusions that you draw should be based on your findings which are seen. So I had a single slide of your finding combining all those patients. From that slide alone, I cannot draw the conclusions that you drew. You have to be very careful when you're presenting a paper to present the conclusions that you draw from your research, your clinical research. It cannot be a broad-based literature survey of all the possible things that can happen. So you cannot, so otherwise you need to spend more time on your patients telling us how your patients gave you this conclusion.
Okay.
Okay,
Yeah.
thank you.
Thank you, sir.